Hello, good evening, all. Am I audible?
Yes.
Good
Okay.
evening. You are audible.
Okay, thank
Good evening.
you. You're all welcome. I'm struggling to navigate through my Zoom. I don't know whether Dr. Ejiro is on the call. I can't seem
Yes,
to.
yes, he's on the call. Good evening. He's on
Since
the
I'm on the
call.
way now. I'm on the way. You can
Okay,
start
so
off. I'll join up later.
okay, no problem. So, Dr. Timi, can you kick off, please? Thank you.
All right. Good evening, everyone. Good evening. Can I be heard? Good evening, everyone.
Good
Good evening.
evening.
Yeah, so I want to welcome you all to this first presentation from the nutrition support of Pharmacists of Nigeria. We really appreciate you all for being here tonight. The presentation we'll be talking more about nutrition support when it comes to a cancer patient. And we all know that this month is a month, coincidentally, is a month for World Cancer Day. February 4 was actually celebrated worldwide. And then this Nutrition Support Pharmacist of Nigeria deem it fit to look at this day and also celebrate in accordance to what the world has already done. So the whole of February, we are talking about World Cancer Month, actually. We know we have other specific days for different cancers, breast cancer, cervical cancer, and all that. But for this month, we are talking about World Cancer Day. So when we talk about nutrition, we know that nutrition is often described as supportive care. Before we start, let me use opportunity to first of all welcome everyone to the meeting tonight. We are also expecting desk officers from the nutrition support of Pharmacists of Nigeria. Pharmacist, the former Mama who first spoke is the desk officer one. Ma, we actually appreciate you for being here today. And Nutrition Support Pharmacists of Nigeria is not standing on its own. It's a specialty group of CPAN, clinical pharmacists of Association of Nigeria. So we want to use opportunity to welcome all our CPAN NEC members present tonight to this presentation. CPAN NEC members present. We want to welcome fellows of the college. We also want to welcome everybody present tonight. CPAN National represented there is our unofficial member, Dr. Ibrahim Bello. Sir, I welcome you to the presentation tonight. I hope you can hear me. So, hello, can I still be heard?
Yes, I can. Thank you.
Okay,
Thank you.
all right. Thank you very much. So, as a way of introduction, I will just say my name is Dr. Timi Preoke. I'm the National Publicity Secretary, CPAN National. So, nutrition, we know, is often described as a supportive care, but in oncology practice, we know it is far more than that because it's a core component of treatment success, patient resilience, and also quality of life. Now, we know that cancer patients, from managing cancer-related issues to preventing treatment, interruptions, and also improving clinical outcomes. So, nutrition care plays a vital role when it comes to cancer journey. Now, as healthcare professionals, especially pharmacists, we know we don't work alone. We work with other healthcare professionals. So it's actually a multidisciplinary team. Understanding the nutritional needs of oncology patients helps us to optimize therapy, to reduce complication, and also advocate for holistic care. So today's section, nutrition consideration for oncology patients, will guide us through practical insights into how nutrition can influence cancer management and what we as clinicians must pay attention to. And we are going to be looking at real world practices. So it's my pleasure to introduce our speaker who will be sharing expertise and valuable perspective as it comes to this important topic. Please join me in welcoming pharmacist Hector Rotimi Orishawo. I hope I pronounced your name well. Our speaker, B-Farm, a pharmacist from the Center of Hope Hospital, Afibo, Ebonyi State, is a member of ASOCLIP, Clinical Oncology Specialist Interest Group, and he has interest in oncology, web lab research, and molecular medicine. So I think we should take our time now to listen to him. So I welcome you, pharmacist Hector Rotimi. Please, you have the floor. Thank you, and over to you.
Thank you very much for the introduction. Good evening, everyone. The CPAN members in the house, the fellows, my senior colleagues, and other healthcare professionals that are here tonight. I really appreciate the privilege to give this lecture this evening. Permit me to share my slide, please. Okay. Please, can everyone see my screen?
Yes,
Okay.
we can.
My name is Pharmacist Hector Oluwadotimi. And in this course of lecture, I'll be talking about some nutritional considerations for oncology patients, optimizing nutrition for cancer care, and best practices. During the course of the lecture, I'll talk about some dynamics between cancer, antineoplastic agents, and nutrition, the impact of nutrition on cancer outcomes and the quality of life. I'll also talk about some nutritional screening and assessment tools, and some nutritional interventions that we pharmacists can implement in the clinical setting. And then finally, I'll be capping it up with the role of an oncology pharmacist in cancer patient nutrition. Without wasting much time, if I was to ask everyone in this meeting to define what cancer is, I know everyone has a definition, but something that will most likely be consistent amongst all the definitions is that cancer is a proliferative disease. And all the symptoms that we see as a result of the genetic mutations that comes with the disease. However, there are emerging schools of thought that are asking us to look at cancer not just as a proliferative disease, but as a metabolic disorder. And all the signs and symptoms you often see with cancer, like persistent proliferative signaling, evasion of growth suppression, activation of tissue invasion, replicative immortality, and induction of angiogenesis, and resistance to apoptosis. All of these things are as a result of disruption in cellular metabolism. And what this does is that it gives us a window or a glimmer of hope that perhaps we could modulate or we could influence the outcome of cancer with the aid of nutrition, or modulating or influencing metabolic activities. And that's why today we are considering nutrition in cancer. On my slide here, I have a diagram, and on the left, we discovered that our cancer patients are in a quagmire. They are always in this loop of cancer, the treatment, and the complications. Because if you have cancer and you're undergoing treatment, one of these phases is likely to affect or influence their nutrition, usually in a negative way. Either treatment Hello, am I still audible, please?
Yes, you are. Please go ahead. Let me just be muting them. Unmute those ones just joining.
Thank you. So I was saying patients are in this rabbit hole between treatment, complications, and cancer. The treatment can result in complications. The cancer itself can result in complications. And then the complications might need further treatment themselves. And each of these phases negatively affects their nutritional status, either through this metabolism or just worsening their whole nutritional affair. And then the end result is that the clinical outcome is worsened. When we are talking about cancer affects nutrition in so many ways. And these are some of the reasons why we see cancer patients come down with poor nutritional status. They have deterioration in taste, their food preferences are altered, they have eating problems, some of them nausea and vomiting, mucositis, depression, anxiety, and pain. Now, it is important to note, like I mentioned earlier, that all of these reasons for poor nutritional status can be caused by both the cancer itself, that is the tumor, or the therapy, that is the antineoplastic agent we are giving them. It has been said that about 50 to 80% of every cancer patient that is taking one form or the other of antineoplastic agent, especially chemotherapy, will experience side effects that affect their nutritional status. For example, nausea and vomiting. This one is very, very common. Almost all the drugs they take will precipitate nausea and vomiting. And the implication of this is that if it is not well controlled, they develop anorexia. Their oral intake is decreased, food and electrolyte imbalance comes into play, weight loss, and then general weakness. We also have constipation and a dynamic ileus. This is usually common with those patients that take vincristine. We also have diarrhea, which is also very common. Patients on actinomycin D, for example, and 5-fluorouracil tend to develop this diarrhea. And this diarrhea in cancer patients can be complicated by proctitis, mucosal ulcerations, bleedings, and perforations. This will also result in electrolyte imbalance and accelerated malnutrition. We also have the cases of malabsorption, whereby even though they are able to eat, they derive from what they are they derive no benefit from what they eat. And then mucositis, stomatitis. It is said that radiation to the head and neck region will almost always induce mucositis, decrease food intake, and result in weight loss in up to 80% of those patients that are receiving them. And another 80% of patients receiving radiotherapy to the pelvic region will develop gastrointestinal symptoms. So all this shows that in every way we are trying to attack the cancer or help cancer patients, the side effect of our regimen, of our treatment plans, can worsen their nutritional status. Talking about malabsorption syndromes, we discovered that our cancer patients will always come down with some deficiencies. And the most common of these deficiencies is the protein energy malnutrition. It is common in almost all cancer. Then we also have the vitamin D deficiency, iron deficiency, especially in hematological malignancies. We have vitamin deficiencies and trace element deficiencies. All of these are common in all the different types of cancer that exist. Now, apart from the deficiencies that come um, with cancer, our antineoplastic agents also have the tendency to interact with the food they eat, complicating the matters. And a very notorious food item in this list is the grapefruit or orange juice, because it's a CYP3A4 enzyme inhibitor. It tends to cause toxicity because drugs are retained longer and they maintain higher levels in the system for a longer period of time. Also, some drugs, when taken with food, their absorption is reduced. Some, their absorption is increased. And some, when taken with antioxidants, their pharmacological effects are neutralized. Now, cancer patients who have altered nutritional status, this altered nutritional status can manifest commonly in three ways. The first is malnutrition itself. The second is sarcopenia, and the third is cachexia. Malnutrition is the most common one of them. About 40 to 80% of patients will experience this during the course of their treatment. And the cause is very, very, very well known. Inadequate food intake as a result of the tumor, the side effects, and complications. Those are what causes malnutrition. For sarcopenia is a progressive and generalized loss of muscle mass and strength. And it leads to muscle weakness, physical disability, poor quality of life, and increased risk of falls and mortality in the elderly patients. And then we have cachexia. Unlike the previous two, cachexia is very stubborn. It really responds to treatment, no matter how aggressive it is. Usually it is insidious, it is persistent, and it leads to loss of skeletal muscle mass. There may or may not be loss of fat with it. And then to even complicate it, the lipolysis and proteolysis that are associated with chemotherapy can even exacerbate this muscle loss in cachectic patients. And like I have said, it is not usually fully reversible in patients by conventional nutritional support. So patients who have a combination of cachexia and sarcopenia, they are very, very prone to treatment toxicity, complications that arise as a result of surgery, and they have shorter overall survival. In addition to this, patients with altered nutritional states,
It's our ref.
they are
Ref.
they are their wounds their wounds take more time to heal. They have risk of developing complications from surgeries. They have impaired muscle functions, and then
Yeah.
our antineoplastic agents may not realize their full effect, leading to extended hospital stay. And then the last is that there is reduced overall survival in these patients. Now, I want to talk briefly about nutritional screening and assessment. As clinical pharmacists, especially in the oncology setting, it is very, very important that at the point where a cancer patient presents to our table, from the very first day, it is important to perform nutritional screening and assessment. Usually, the tools that are used for this procedure are very, very brief, simple, and sensitive. They utilize parameters such as the food intake, their weight loss, BMI, age, and disease state, if there is any. And examples of these screening tools, we have the Malnutrition Universal Screening Tool, the MUST, the Nutritional Risk Screening Tool, 2002, and then the MST. The table higher below shows the parameters each of these tools utilize. Here is an example of what the Malnutrition Universal Screening Tool looks like. The Malnutrition Universal Screening Tool utilizes the BMI, the intentional weight loss, and then the presence of illness or not. And it is scored. Each of these parameters is scored between 0 and 2. Then, depending on the score, the next procedure can be decided. However, I want to dwell more on the NRS 2002. This particular tool was designed by the European Society for Clinical Nutrition and Metabolism for use in the hospital setting. It is very, very brief and easy to administer, and it is the recommended screening tool for adults in the hospital who may have cancer. The NRS 2002 screening tool has two parts. The first part assesses four parameters. First is the BMI. The second is the weight loss within the last 3 months. The third is the dietary intake in the last, and the fourth is a disease state. When you ask your patients any of these four questions, how their BMI have been in their BMI is, if there's been any weight loss, if there's decreased dietary intake, and there's illness, if they respond no to any of these parameters, then there's no need to proceed to the second part of the tool. However, that does not mean you should not continue screening them. You continue to screen them as often as possible, probably at every cycle of treatment or every time they present to the hospital, you continue to screen for for malnutrition. If, however, the patient responds positive to any of these questions, then we can proceed to the next part of the tool. The final part, this part calls two main components, which is the impaired nutritional status and then the severity of the disease they have. However, it also accommodates age adjustment. That is for older adults that are over 70 years. So when you put together the scores from these two components, we have an interpretation as shown in the table on the slide. So a patient can be judged to be at no nutritional risk, at nutritional risk, or at high risk. If after using this tool, we have adjudged the patient, a cancer patient, to be at high risk, there is need for further comprehensive assessment. And that's where tools like the scored patient-generated subjective global assessment comes in. These tools have been validated and they are comprehensive and they are specially designed for patients with cancer. Unlike the NRS 2002 and the MUST screening tool, the PGSGA, which in full is the Scored Patient-Generated Subjective Global Assessment, incorporates respondents from the patient and the professional as well. So it's not a one-sided screening assessment. The patient has the opportunity to contribute his own assessment, and then the professional that is administering the screening tool also has the opportunity to make his observation known. This PGSGA also has two parts. The first part is for the patient. That's where the patient feels. Usually it comes in 4 boxes, and the 4 boxes assesses different parameters. The first box will usually assess the weight history. You have a question like, what is your current weight? What was your weight in the last 6 months or last 3 months? Documented. The next box will have will assess the food intake. Probably the food intake has decreased within the last few days, last few weeks, last few months. The third box will assess impact symptoms like nausea, vomiting, diarrhea, pain, and there's a host of options for the patient to choose from. Then the last part assesses the activity and functionality of the patient. Is the patient bedridden? Can they move? Do they require effort? So this aspect of the PGSGA is fueled by the patients themselves. The second part is for the professional that is administering the screening assessment. It can be a dietitian, it can be a nurse, it can be a physician, it can be a pharmacist. What the professional here looks for is the disease and the age. Is there metabolic demand and stress? And then what can you observe while looking at the patient? Does the patient seem to have ascites edema, muscle wasting, or loss of fat? So all of these parameters are scored using the PGSGA to arrive at a score. Depending on the score, we have different grades for them. So a patient can be adjudged to require no intervention, maybe family or patient education, or there might be need for intervention by a dietitian, or the intervention might be urgent. Now, I should mention that for patients who are obese, it is not always effective or safe to use It is not always effective to use the weight loss as the only metric to determine malnutrition in obese patients. If a patient is obese, it is better to use weight loss, the BMI, and the food intake to assess malnutrition in this patient. However, to harmonize what the definition of malnutrition looks like, the Global Leadership Initiative for Malnutrition, the GLIM, agreed upon a three-step procedure to assess or to diagnose a patient as being malnourished. The first one is the patient should have passed a pathological screening test for risk of malnutrition, and this can be done with any of the tools that I had already mentioned. The second criteria is that the patient should present with at least one phenotypic criteria of malnutrition. That could either be weight loss, low BMI, or low muscle mass. And the third is that there should be at least one etiological criterion for the malnutrition that is observed. Is it because the patient is not eating well, or is it because there are systemic activities that are affecting the patient's nutritional status? So if the patient passes the first criteria, the second criteria, and the third criteria, he or she can be judged to be malnourished. And then the malnourishment can be as a result of starvation or as a result of inflammatory processes. Now, what interventions can we as pharmacists implement in our various clinical settings to help our cancer patients? We all know that cancer can occur at any part of the body, and the patient can present to the hospital at different stages of their cancer. And then each patient will have different medical history. And that is why I cannot emphasize this enough that whatever intervention that we are using, it has to be individualized. It has to be tailored to that patient. And something about nutrition is the food or the diet or the nutrition is the only factor that patients know that they have control over. In fact, both the patient and the family members of the patient and the caregivers of the patient, they recognize that adequate food intake is important, it's essential to maintain the daily activity of the patient with cancer, to maintain energy, to maintain functional capacity, and to overcome the treatment more successfully. And thus, when the patient acknowledges or knows that the intervention we are implementing for them has been adapted to suit them and has been individualized for them, it empowers that patient with a feeling of control and makes it easy for psychological modulation. So the individualized intervention is highly effective to psychological modulation and contributes eventually to the patient's quality of life and modulate late treatment morbidity. We should always, in the course of the intervention, as long as the patient has a functioning GI system, our de facto intervention should always be nutritional counseling, with or without oral nutritional supplement, unless the condition of the patient demands otherwise. What criteria perhaps might we look at before we can decide, oh, okay, this patient nutritional counseling won't be enough. We need to place the person on some artificial nutrition or the likes. Well, there are four major criteria to look at in this aspect. In determining whether to switch a patient from oral therapy to artificial nutrition, there are four criteria. The first is that, is this patient having inadequate food intake, or is inadequate food intake anticipated for more than 10 days due to a surgical procedure, a chemotherapy, or radiotherapy? That is one. The second is, if food intake is going to be less than 50% of the requirement for more than 1 or 2 weeks, artificial nutrition should be considered. The third is, if it is anticipated that undernourished patients will not be able to eat and or absorb the nutrients they will need for an extended period of time as a result of the antineoplastic agents or treatment they are undergoing. And the fourth is if the tumor they have, like in the case of those with the neck and head cancer, if the tumor they have impairs oral intake and food progression through their upper GI tract. So if a cancer patient meets any of the four criteria that I just listed, then we can decide, or it can be decided alongside the team that is managing such a patient, to switch the patient from just normal oral supplementation to artificial nutrition, which could be either parenteral or enteral, as shown in this workflow. Now, artificial nutrition, like I mentioned earlier, it could be either enteral or parenteral. If we have decided that the patient is in need of artificial nutrition, which one which one should the patient go for? Usually, the choice depends, or it takes into account of the type of tumor, the complications, the treatment plan, the prognosis, and the patient's overall physical status. However, as much as possible, enteral nutrition should always be preferred over parenteral nutrition because not only is it safer and easier to administer, but it minimizes risk of infection and it is less complicated than parenteral nutrition or parenteral support. Some patients, enteral nutrition will be contraindicated, especially those with intestinal obstructions, intestinal ischemia, intestinal hemorrhage, anything that makes their intestine or their GIT unfunctional. We know enteral nutrition will not be indicated for those patients. And so parenteral nutrition becomes the first option of choice in patients with intestinal failure. Now, whichever nutrition, artificial nutrition that has been provided to the patient, especially cancer patients, we want to always pay close attention to the amino acid constituents of these preparations because of the tendency for them to always lose muscle mass and the weight loss. Special attention should be paid to the amino acid constituents of their nutrition. And so it is recommended that up to 2 gram per kilogram per day is required to stimulate synthesis and anabolism in this patient and to mitigate against catabolism. I would also like to talk a little bit on immunonutrition. Immunonutrition is a special type of artificial nutrition. It is targeted basically at the immune system. It contains some higher than normal doses of components that influence or modulate the activities of the immune system. Example of some of these components is the arginine, the glutamine, omega-3 fatty acids, and the nucleotides. All of these are important components that helps the immune system to function well. And it has been shown that immunonutrition is very, very relevant for patients who are perioperative, either before or after surgery. It has been shown that immunonutrition reduces postoperative infections, complications, and hospital stay. It improves the immune response and inflammatory markers, and it enhances their treatment tolerance. Now, let us look at some considerations in surgical oncology patients. These are patients who are about to go into surgery. Usually, it is recommended that the enhanced recovery after surgery protocol be applied for such patients. This protocol has three main principles. The first one is that you want to always screen for malnutrition and give additional nutritional support if necessary, and avoid preoperative fasting. Now, if we discover that our patient is malnourished, we know that it will be necessary to delay any surgical procedure in such patients. This allows for some days or weeks of pre-surgical support, so to speak, and allows the patient to build up physical and psychological fitness before the surgery, helps them avoid muscle loss during adjuvant treatment, and reduce post-operative muscle loss, and helps accelerate recovery after surgery. In this patient, if if it has been deemed that these patients are at no risk of aspiration, they can be allowed to eat solid food up until 6 hours before their procedure and drink clear fluids up until 2 hours before anesthesia. The second principle that guides the enhanced recovery after surgery protocol is that preoperative carbohydrate treatment should be considered, as well as the reestablishment of oral feeding on the first post-operative day. If it is anticipated that after the surgery, the cancer patient will be unable to eat for more than 7 days, it is advised that we start nutritional therapy as soon as possible, even if they are well nourished. And if oral intake is possible, it should start immediately after the surgery without interruption. But we know that that is subject to the patient's tolerance. If the patient does not tolerate it, we won't force it. However, if oral nutrition is possible in this patient, enteral nutrition should be initiated in them within 24 hours, preferring the standard polymeric formulations.
Presentation lọ́jọ́ Monday. No, is
The
this
third,
nutrition?
the third principle that guides the enhanced recovery after surgery protocol is early mobilization. We want to get our patients on their feet as soon as possible. So those are the three guidelines that guide surgical oncology patients. We should try and implement this as much as possible. In patients who are at risk of aspiration, instead of the 6 hours that was recommended, it can be the standard 12 hours so that there is no complication that arises from the surgery they undergo. Now, for patients who are undergoing chemotherapy and for patients who are undergoing radiotherapy, the main or the most important thing for this patient is counseling, nutritional counseling. We know that their chemotherapy and radiotherapy will almost always cause or stimulate nausea, vomiting, diarrhea, and mucositis in this patient. And so it is very, very important we counsel the patient based on their nutritional and clinical parameters that we observe, such as their nutritional status, the dietary intake, the food they tolerate and the food they don't tolerate, the patient's psychological status, their cooperation, and if there's need for help or support of others in the act of eating. However, when deemed necessary in this patient, oral nutritional supplements can be provided for them. And when the mucositis or the complications, the stomatitis that may arise from the chemotherapy or radiotherapy is severe, then we can consider artificial nutrition in this patient. It is said that in patients that are undergoing chemoradiotherapy, parenteral nutrition is not recommended and should only be last resort when enteral nutrition cannot provide the adequate requirements for such patients. Now, I'm going to talk about some specific diet interventions in patients with cancer. And the most important of these diet interventions is with respect to their protein intake. Adults per kilogram per day of protein. However, please, am I still audible?
Yes, you are.
Yes, yes.
Okay, thank you. However, cancer patients can need as much as 2 grams per kilogram per day. However, a consensus puts an average at 1.2 to 1.5 grams per kilogram per day. But they are always in need of protein. Glutamine, and creatinine are very essential in this patient because they are important for protein synthesis, for muscle growth, and to prevent muscle breakdown. So whichever parenteral preparation, artificial nutrition that is being provided for these patients, we always want to ensure that they are very rich in these amino acids. And if they are not on parenteral and on artificial nutrition, if they are taking their normal oral diet, we want to ensure that it is always rich in protein. animal proteins, and even plant proteins so that we can mitigate the rate at which these cancer patients, their muscle breaks down. We can mitigate against that process, and we can stimulate protein synthesis and muscle growth in these patients. Another important thing is consumption of fish oils. Fish oils contain polyunsaturated fatty acids like the eicosapentaenoic acid and the docosahexaenoic acid, which have been shown to affect the growth of tumor cells directly and their growth. In fact, it has been said that these two molecules have, have bolstered the effect of chemotherapy, enhanced tumor toxicity to antineoplastic agents while protecting non-tumor tissues. Essentially, it is expanding the therapeutic windows of some of these some of these antineoplastic agents. In addition to fish oils from purified coconut, for example, and palm kernels are excellent sources of energy that are less inflammatory and also promotes ketogenesis and protein sparing. So we can always encourage our patients to consume more of these fish oils during their treatment. Whole grains are also very important in moderate quantity, of course. Whole grains like millet, maize, brown rice, oats, and popcorns. These whole grains contain antioxidants, phytochemicals with antioxidant properties that have anti-tumor properties. And so it is very, very important to be included in their diet. We also have the probiotic and prebiotics. The probiotics are generally safe in cancer patients unless if they are immunocompromised. This helps to mitigate and alleviate the symptoms that cancer patients will otherwise face during their course of antineoplastic agents. And this is because they have the capability to break down inflammatory molecules, for example, degrade carcinogens in the lumen. They can modulate immune response, and they also strengthen intestinal barriers by maintaining homeostasis in the GI system. And examples of probiotic is the yogurt and some local diets like the locust bean, pap, kefir, and kunu. Ketogenic diet. I know that the ladies in the house might be familiar with ketogenic diets, usually recommended for people who perhaps want to lose weight. However, it has been shown that it could be of importance or relevance to patients with cancer. The mechanism of action of ketogenic diet is based on a study that was performed by a German scientist named Warburg Otto. He discovered that even though there is enough oxygen in the system, cancer cells tend to want to prefer glycolysis to synthesize ATP for energy, which is a very, very inefficient system. However, the body can always switch to oxidation of fatty acids for the energy they need. And it is on this premise that the ketogenic diet is based. So the aim is to starve the cancer cells or the tumor cells of the much needed glucose they will need for that glycolytic process. However, the full benefit of ketogenic diets is not realized in all cancer. And so more research and more investigation is needed. But however, in some studies, it has been shown to be very, very beneficial. Another diet intervention is the intermittent fasting. The MOA is also similar to that of the ketogenic diet. The aim is to try and starve the cancer cells, the tumor cells, of the needed glucose. However, it has also been shown that intermittent fasting helps to lower glucose, obviously. It induces autophagy, it reduces inflammation, and it may even sensitize tumor cells to the treatment while protecting the normal cells. But we know we won't use this kind of intervention for someone who is already malnourished or who is cachectic. So it is suitable for only patients that apparently have good nutritional status. Micronutrients. The American Institute of Cancer Research and American Cancer Society and the European Society for Clinical Nutrition and Metabolism has recommended the use of multivitamins and minerals as supplement in cancer patients. However, we want to avoid the use of high dose multivitamins when there is no specific deficiency for it. So if someone that is not having scurvy and they are taking high dose of vitamin C, that is not recommended. Daily dose, doses that are close to the recommended daily dose are allowed, but high dose where there is no obvious deficit of the vitamins is not encouraged. Some studies have also shown that muscle loss or muscle wasting is usually associated with low levels of vitamin D. And so it is important that we always supplement our patients with vitamin D in order to optimize the effect of any protein or amino acid supplements that we are administering to them. Now, patients with cachexia and sarcopenia. If you remember previously, I had mentioned that cachexia is very stubborn. Okay, so let me mention that cachexia is on a spectrum. A patient can be judged to be precachectic, cachectic, or have refractory cachexia. Patients who have refractory cachexia will usually not benefit or derive any benefit from whatever nutritional intervention we are giving. And so for these patients, palliative therapy is what is prioritized for them. However, for patients who are still precachexic or who are just at the cachectic stage, they may benefit from nutritional interventions. And the goal for any intervention that for this patient is to preserve and grow their muscle mass. And so the lifestyle they live, the nutritional interventions we are making is to be tailored to achieve this goal. And so, if you are trying to preserve muscle mass and you are trying to grow muscle mass, the very most important thing here is their protein intake. It has to be gauged regularly, and we have to ensure that they are meeting their daily protein requirements. Also, we want to find out what exactly is causing or is predisposing these patients to the cachexia or to the sarcopenia. Is it inadequate food intake? Are there inflammatory processes that are going on in the system that may be revealed by laboratory tests? Based on these findings, we can know how to mitigate against this cachectic process. Like I said, amino acid and protein supplements are the pillar of nutritional interventions in these patients. And also vitamin D supplementation is also very important in them. So to complement the amino acid consumption and the vitamin D, as much as they can or to the extent tolerable for the patient, resistance and aerobic exercises are important. These will prevent muscle disuse or muscle atrophy, and it will promote anabolism in such patients. Refeeding syndrome. Refeeding syndrome is a potentially fatal side effect that may occur when we try to introduce nutrition rapidly to a patient that has been in a state of starvation for an extended period of time. Usually what happens in this patient is that because of they've been in a state of starvation for a long time, the stores of phosphates and essential electrolytes in the cells are used up in trying to maintain or achieve their needs for ATP synthesis. And then due to homeostatic mechanisms, the levels of these electrolytes are maintained in the serum. Okay. And then obviously because they are starving, insulin levels in the serum drops. When we now rapidly introduce nutrition into this patient, this could be enteral, it could be parenteral, it could even be oral, because they've been starving for a while, there's a spike in the glucose levels in this patient. And this sudden spike of glucose levels, excuse me, it results in stimulation of cell generations. And also the cells sort of wake up and want to start growing and developing. And so there is a simultaneous drive of the electrolytes that were already in the serum. They are driven into the cells. And so the end result is that there is a catastrophic drop in the serum levels of these electrolytes. And that is very dangerous. The patient becomes prone to hypokalemia, hypophosphatemia, hypomagnesemia, and all the hypos that you can think of. And this is very, very dangerous in cancer patients. So to avoid this syndrome, it is advised, it is recommended that when we are starting them on nutrition, on any form of artificial nutrition, we want to start at less than 10 kilocal per kilogram per day, and then increase stepwise over the course of days until the body can tolerate. Also, thiamine should be administered to this patient 200 to 300 milligrams per day for 3 days. And then other multivitamin supplements can also be provided for this patient. The serum electrolytes will always be monitored in this patient. And if it is observed that their serum phosphate levels is dropping, IV phosphate 50 millimoles over a period of 24 hours can be used to raise serum levels to a safe zone. Here I have some list of local diets that have been shown through 1 or 2 studies to have anti-tumor or anti-cancer properties. So we can recommend any of these for our patients. However, we always want to keep in mind, or always want to ensure that none of them is interacting with whatever anti-neoplastic or chemotherapy agent they are on. Now, we are oncology pharmacists of our patients. Like the moderator had earlier mentioned, when it comes to cancer patients and their management, especially nutrition, it is not a one-man's job. It is a collaborative effort. The pharmacists, the dietitians, the physicians, the nurses, the oncologists, we all have a role to play. But for us as pharmacists, one of the main important things, or some of our goal in managing the nutrition in cancer patients are, first, we want to manage the artificial nutrition the patients are on. In some cases, you may even need to compound the artificial nutrition, although most of our facilities here don't have the resources for that. But in some countries, pharmacists have to compound or prepare the nutrition for these patients. So pharmacists, we evaluate, we prescribe and adjust, we compound and we monitor the parenteral or enteral nutrition cancer patients are on. We check for incompatibilities, we check for complications. We also check for drug-nutrient interactions during the course of management. We always want to, if there's going to be an interaction, probably with the food they are taking, like with grapefruit, for example, or on the timing of the medications or of their nutrients, it is our job to provide relevant information and identify and mitigate any potential interactions in that regard. We also maintain or manage micronutrient and supplements. We assess the patients from time to time for deficiencies, and then we recommend or initiate supplements to avoid minerals or vitamins. And then we always remember to advise or counsel our patients to avoid high dose antioxidants, because these have the tendency to neutralize or cancel the effect of cancel the pharmacological effect of their antineoplastic agents. Also, patient education and counseling, which is, in my opinion, is the most important role of the pharmacist in this regard. It is our job to reinforce at every meeting time, every time the patient comes to our desk, we reinforce dietary advice, we reinforce the medication timing with respect to meals, and inform or educate them in advance about the side effects that may come with their medications and with the nutrition they are on. Then lastly, we collaborate, we contribute to nutrition screening, supportive care plans that aligns with international standards like guidelines from the ESPN and the ASPEN. So, what have we been able to talk about? First off, I talked about the effect of cancer and antineoplastic agents on nutrition. I mentioned some deficiencies and drug nutrients that come around as a result of the cancer. as a result of the antineoplastic agents. We also talked about impacts of nutrition on patient outcomes, where we talked about sarcopenia, cachexia, and malnutrition. I also mentioned some screening tools for nutritional assessments, like the MUST, the NRS 2002, and the patient-generated subjective global assessment tool, which have been specially designed for cancer patients in the clinical environment. And I mentioned some nutritional interventions that should be considered for patients undergoing surgery, patients undergoing chemotherapy or radiotherapy. And I talked in part with respect to the refeeding syndrome. And lastly, I mentioned our role as oncology pharmacists in the management of cancer patients and their nutrition. Here are my references, and thank you for listening to me.
Thank you very much, Pharmacist Hector Rotimi Orishawo from Center of Hope Hospital, Afikpo, Ebonyi State. Afikpo happened to be where I started my practice from Mater Misericordia Hospital in Afikpo many years ago. This has been a very, 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 very wonderful presentation. When I saw the slides initially, I think I sent message to say that this is the best slide I've seen in a very long while in all the presentations. And indeed, the presenter will not only prove that the slide was the best I have seen, it was also one of the best presentations I've been part of. And I'm privileged to have anchored this presentation. First, I want to thank Dr. Timmy for starting up on my behalf. My name is Ejiro Akpowoma, and I was supposed to be the host, but I was tied up at work. Once again, thank you very much for a wonderful presentation, and I want to thank all those who've been part of this very special presentation. Now, before we proceed with questions and contributions, I want to appeal that Pharmacist Hector be made to do this presentation, give this presentation at the General CPAN house, because this is very this is very useful information for all pharmacists. So without wasting much more time, the floor is now open for questions and contributions. So please, you could raise your digital hands if you have comments or questions. Okay, while we are waiting for participants to decide on questions to ask or contributions to make, I want to start off by adding to what has been mentioned as a rule of thumb when it comes to nutrition support, especially with parenteral nutrition. The rule of thumb is when the GI is working or is functional, you use it. You only consider parenteral nutrition when the GI is not feasible to be used, or when it's not providing insufficient nutrition for the body. At that point, that is when parenteral nutrition is considered. Now, the presenter, Pharmacist Hector, also listed a lot of screening and assessment tools. Yes, these are the ones available now. Okay, before I proceed, I think I have a hand up. Pharmacist, let me see. Dr. Bilikisu.
Good evening, everyone. Thank you for the opportunity. And again, our presenter, Pharmacist Rotimi Rotimi, for a wonderful and excellent presentation. I just wanted to add little contribution. Concerning the malnutrition screening, yes, it was well presented. I heard him saying concerning the screening that all the multidisciplinary has a role, yes. But the role is more to a particular discipline, and this is the nurses. The reason why I said it is that if, for instance, in a hospital, and when you have a nutrition support steering committee and you have a nutrition support team also, if you don't spell out categorically that, okay, this role is for so discipline, you might be missing it. And at the end of the day, some discipline may be thinking you are hijacking their role. So, first of all, there is need to have a nutrition support steering committee in all our institutions. Then under it, there will be a nutrition support team. The steering committee acts like, as a legislative body, and the nutrition support team also, they are always at the bedside of patient to cater for their nutritional care. So nurses, they are the one that are in charge of malnutrition screening or nutritional screening of patients. The physician, they can identify the risk, and when there is a red flag, then they initiate referral. And they send the referral to the dietitian. The dietitian will do the detailed assessment and nutrition plans. Just like what he said, also pharmacists will be monitoring drug nutrient interaction, compounding of CPN in a clean room. So I think that's what I wanted to ask. Then again, or to add, again, for instance, in our setting now, we have adopted the MUST malnutrition universal screening tool, and we have adopted the York Hill malnutrition screening tool. That is for pediatrics, 0 to 16 or 0 to 17. So the MUST, the NRS, the PGSGA can also be adopted, depend on your setting. Like us now, we have adopted MUST and York Hill, and we extracted what we think in our setting we can handle. So it's not necessarily you must follow, though all of them are validated, yes, they must be validated too, but you just have to use screening tool based on your setting, what is achievable, what you think that you can achieve when you start it. And I think that's all I wanted to add. Thank you.
Thank you very much, Dr. Bilikis. That is one of the pillars of WASPEN. She has just spoken in details part of what I wanted to also summarize. So I will want to appeal to Pharmacist Hector, if he's not a member of WASPEN already, to quickly register with WASPEN. You have strong hands-on. So like Dr. Bilikus mentioned, in the hospital, the nurses are responsible for screening, while the dietitians are responsible for assessment. And WASPEN as a group is pulling together all this multidisciplinary team. And so like she mentioned, the tools her center is using at the national level, WASPEN is also trying to come up with a national, a universal, nationally acceptable tool for the whole of the country, which all the various professions will be strongly part of. In addition to what Dr. Bilikisu mentioned, okay, I think this is a different point. When you talked about preventing refeeding. Now, before I quickly rush to this, while in the hospital, this screening, nutrition screening and nutrition assessment are specifically for different professions. At the community level, as pharmacists, it is important that we also understand the use of these tools, because at your community pharmacy, you will be responsible for doing all three: the screening, the assessment, and then providing the nutritional support itself. So for prevention of refeeding in practice, what we do is, when you've calculated the daily energy requirement for the patient, you run at half the required calorie for the day. So if the patient requires 2,000 kilocalories for a day, you run for 24 hours, 1,000 kilocalories. That makes it easier for the body to gradually assimilate and prevent refeeding syndrome. And also, you're able to monitor the patient is able to tolerate, especially the lipid component of the TPN. Now, I'm making reference to TPN because that's our primary responsibility when it comes to nutrition care in the hospital. So the floor is still open for more comments and contributions and questions, sorry. And Pharmacist Hector, you are also free to make more comments. So it looks like we are all fully, we understand perfectly what has been taught. And again, I want to thank you very much, Pharmacist Hector. For a long while, I saw a presentation, I just saw a presentation where the slides were not being read. It was obvious that the material was part of you and you were part of the material. Thank you very much for this wonderful presentation. The slides will be distributed so that we can read extensively and assimilate and see how we can implement. It looks like we don't have questions on the chat box and nobody's hand is up. So Pharmacist Hector, any last words for us before we get the vote of thanks? Okay, I see a hand now. Dr. Obianuju Ayobosi have
Yes, sir.
the hand up.
Good evening. Thank you so much, Farm Hector. The lecture has been quite impactful. Please, I need a little clarification on use of some of these commercial protein drinks like Ensure, Complan for cancer patients. Can you throw more light on that? I know some people, some cancer patients, they drink it. Can you talk more on it? Thank you.
Okay, from Hector, please let's just take Dr. Amibo's question or comment before you respond, please? Thank you. Dr. Abibo, please, you can go ahead. Dr. Amibo, we can't hear you. Okay, he's off. I think he has network issues. So, Pharmacist Hector, please, you can go ahead.
Okay. Thank you. So with respect to the protein drinks, I had mentioned that for the artificial nutrition, they can come in different form. On my slide, there were examples. Some come as supplements and some come as drinks. Usually, what concerns us as pharmacists is the content of such preparations. Okay. Usually, there are some preparations that are specifically for certain conditions, like patients with cancer, patients with diabetes, patients with one illness or the other. However, I stressed that for patients with cancer, one of the very most important things for them is always the protein content or the amino acid content. Okay, so if just like my host had said, if their GIT is functioning well and they can drink these things normally, it's fine. It supplements their daily protein intake and it reduces or mitigates the chance of muscle breakdown or protein breakdown, and supplements anabolism with in addition to exercise, aerobic and resistance exercise in this patient. And for some, which are not in the form of drinks, the supplements, for example, we have some supplements like the L-arginine supplement, thionine or thorine supplements. All these supplements, they help to boost the immune system. Their use case is majorly for patients that are undergoing or that are to undergo surgery, because the constituents of some of these preparations target the immune system. They bolster immune response and help the body fight inflammation or fight infections and complications that may arise from surgical procedures. But that does not mean other cancer patients does not benefit. The amino acid contents of these things is very, very important for such patients. And so we should encourage it. We should encourage our patients to use, our cancer patients to take this if find it in the local market. Personally, drink the amino acid drinks, but I'm familiar with the supplements in my area. Answer your questions, ma'am.
In addition to what Hector just mentioned, like I mentioned earlier, if you are in the hospital, it is the dietitian's responsibility to determine which of the ensures. However, like Hector said, you have specific oral feed for specific disease states. That if you are in the community where you determine, then it's important to take a look at the content of what you are giving out and see if it is ideal for that patient, and consider other medications the patients will be on, because you could also have interactions. But if you're in the hospital for the oral feeds, that is the responsibility of the dietitians. You can only, as you dispense, while reviewing the patient medication, you want to look at possible interactions with the content of the feeds and the other medications the patient is on.
Yeah, thank you so much.
I think Dr. Amibo is back. Please, sir, can you unmute and ask your question, please? Dr. Bilikisu, just a moment. After Dr. Amibo, will come up to you. Okay, we still have.
Hello.
Hello,
We
can
can
you hear
hear you,
me?
sir. We can hear you, sir.
Yeah, good evening, everybody. My name is Dr. Kingston Yubo. I want to begin by appreciating the presenter for a very enlightening presentation. A lot of us have benefited from the presentation, no doubt about that. I also want to appreciate my very good friend and brother, Dr. Ejiro. It's nice to hear your voice again after a long while. As a matter of fact, when I saw the advert or poster with you as a moderator, I was really excited, and I actually look forward to interacting with you tonight. So I'm glad that I'm able to interact with you tonight. I appreciate the role you have played towards success of tonight's presentation. I'm also happy to hear to observe that you are still very much a part of this nutrition support program of WASPEN, in the WASPEN initiative and nutrition support. So I appreciate you for making our time to be here with us tonight, and for a good job you have done moderating the program. So I just encourage you to keep it up. Well done. And thanks once again to the presenter for a very good presentation. Thank you.
Thank you very much, sir. We are just following in footsteps of mentors like yourself. Okay, let's listen to Dr. Bilikisu. Just a moment, please. Let's hear from that's you. I'm seeing Mama there.
Hello, thank you very much. Farm Hector, I really appreciate what you did tonight. I just want to, the pharmacists that asked about Complan, we're asking about clarification, maybe whether it's useful. I just wanted to add that let's remember that cancer patients, one of their problem is weight loss, and Complan.
We've lost your audio.
But also the calorie content is quite high, and it's basically helps in weight gain, so it will take care of weight loss. Thank you very much. And Dr. Ejiro, I really appreciate you. Thank you very much.
Thank you, ma. With Dr. Bilikisu.
Okay,
Please, you
thank
can.
you, sir. Thank you, sir. I just wanted to lay emphasis on screening. Even at the community level, the pharmacist has to adopt screening tool and use it effectively. Because it is when you understood that, okay, this patient is at low risk or at high risk, then you decide. At low risk means a pharmacist can intervene, giving all these type of things that we are talking about, either oral supplements or whatever. But at high risk, because you have to, first of all, conduct screening. Let every pharmacist at the community level knows that it's not just by, okay, because of what I asked. You just have to use a tool, a validated tool that can say, okay, this patient at the end of the day is at risk, so that you can manage. But if it is high risk or the patient is already malnourished, I think the best thing is to give a referral to the appropriate, maybe the next level of the person that, okay, can say, okay, determine, okay, this is a type of malnutrition, so that it can be adequately treated. Thank you.
Thank you very much, ma, for your contribution. Francis Hector, please, are you a member of WASPEN currently?
No, please.
Okay. At the end of this lecture, we would love to have you as a part of WASPEN. And this also is an invitation to everyone who attended this lecture who are not yet members of WASPEN. And I also want to use this opportunity to invite all to the WASPEN conference coming up at at Asaba, to be anchored primarily by FMC Asaba. And I think the chairman of the LOC is here. I think I saw my sister Pedwa, Ape, my sister Pe. Yes, Ekedegwa Ape. My chief, please, can you unmute and throw more light on the conference? Is Pharmacist Ekedegwa with us? Okay, looks like he's not with us. So the WASPEN conference is coming up in June, and some of us would have been seeing the flyers. It would be nice to have as many as we can present, because we pharmacists are the one driving the conference, even though we have other members of the healthcare team strongly represented at every conference. But we want to make sure we retain ownership of clinical nutrition support, especially when it comes to parenteral nutrition. At this point, I want to call on, or I even just wanted to call her now. Our hand is up. Dr. Okeogene Timipre.
Yeah, good evening, everybody. Again, I want to really appreciate you, our presenter, for a job well done. I appreciate you so much. And we look forward to getting this slide, and then we appreciate, and also we look forward to having you again in another time for this kind of presentation. Then just like Dr. Amibo pointed out, I also want to use this opportunity to welcome Dr. Ejiro back. Will I say, I don't know what happened. At a point we didn't get to see you again. So it's an opportunity. We appreciate you. One time we were in nutrition support, and then I was even saying, when you were talking about WASPEN, I said, yeah, it's good. We are one. But talking about WASPEN in nutrition support, let's forgive you for talking about it in nutrition support program, which is a specialty group of CPAN. We are together. But I also want to encourage our presenter, if you are not a member of CPAN, I don't know if you are, but I know you also mentioned that you're a member of ASOCLIP, and you are your interest is in oncology, and you're a member of the oncology special interest group of ASOCLIP. I want to use the opportunity to also mention to you that this presentation, we have 15 specialty groups in CPAN, even though we work together, and oncology is one of the specialty groups. We also have a DEX officer, and I'm also encouraging him with this kind of beautiful presentation. We would love to have you in CPAN also. And yes, I'm a member of WASPEN, and we are also expecting the conference, and all road leads to Federal Medical Center Asaba. But I also want to encourage us to keep this specialty group active, especially now that West Africa Postgraduate College of Pharmacists have already started. It is recognized in the college. So that makes it, a very good opportunity for us if we can. So while I was moderating before Dr. Ejiro came on board, I did mention that NEC members of CPAN, I recognize that even though some of them were not here. So I want to use the opportunity to recognize the national chairman of CPAN. She's here, Dr. Moinu Wafo. I just want to appeal that before we close this meeting tonight, she should say something. So thank you so much, Famejiro, Dr. Ejiro. We
I was
appreciate
actually
you.
leaving the vote of thanks for Dr. Morin Wafo.
Okay. So Dr. Ejiro, we hope to see more of you. It's not only Dr. Amibo that is hoping to see more of you. We hope to see more of you in CPAN, not just in nutrition support. Thank you.
Thank you very much, Doctor. Okay. I just want to specially thank the group for staying alive. Usually, the start of anything is turbulent, but so far we've been able to remain active. And I hope to continue remaining active. The only challenge is that there are a lot of engagements, but I do join some of the meetings, but not necessarily commenting because most times I'm in situations where I cannot speak. But I want to thank all for keeping the dream alive. And special thanks to Dr. Momo, because, pharmacist Hector. I see Dr. Ifoma Moma, your hand is still up. That's why I was calling your name now. You have more comments or contribution? Or is it the old hand?
Yes, I do. As you mentioned that you're inviting Farm Hector to Aspen and Dr. Timi is inviting him to CPAN. Of course, yes, great. But from his voice, I want to say we are going to sponsor him. He's a small boy, so I'm asking for sponsorship for him. So, Dr. Ejiro, is a challenge to you. He's just a small boy. So I'll appreciate sponsorship for him.
This
And
acceptable.
Dr. Timi, challenge to both of you. Thank you.
Thank you, ma. Noted.
Noted. This is a real setup. It's
Yes.
okay.
Actually, I saw the advert. I even went to Zoom to see. I can see he's a young pharmacist. He's
Yeah.
YPG. We really appreciate you. Thank you
He's
so much.
actually a
Thank
baby.
you.
He's actually a baby.
You said he's
Thank
actually
you.
what?
A baby. It's not just young, he's a baby.
Oh, thank you. Thank you for telling.
That's nice. I can see Dr. Morin on the list again. Is Dr. Wanfo still on the call? I don't think so.
Dr. Timi can on her behalf. So that we
Okay.
can yeah.
Dr. Simi, please, can you give the vote of thanks on behalf of Dr. Morin, please?
Because I've already spoken, let Dr. Ibrahim Bello, our CPAN national on this call. Sir, please, can you give a vote of thanks on her behalf?
I'm not seeing him.
No, he's the CPAN national. Anytime you see CPAN national, just know it's Dr. Bello.
Oh, that's okay. Dr. Bello, please.
Okay, good evening, everyone. I want to sincerely thank us for participating in today's very interesting and impactful lecture by the Nutritional Support Group. It has been very engaging, very educational. I want to thank the speaker, the moderator, and all the participants. And I pray that CPAN continue to grow stronger and stronger. And as we are about to go and rest and further persist, I pray to Almighty Allah to come and be with us, keep us safe and blessed. So thanks for coming. And next week, by God's grace, it's going to be another interesting clinical meeting. Bye for now, and good night. I'm busy in transit, so that's why. Dr. Giro, from far away, you are welcome back. We are calling you. I know you are with us. You are always around. You are welcome back
Thank you
to
very much,
our
sir.
new. So it's nice having you around. And everybody, I say good night and see you again, God's grace, next week. So unfortunately, the lecture is not stream live, but I'm going to download and upload it again to YouTube for future references. Thank you.
Wow, that would be lovely. Sir, we'll be so excited.
Yeah.
Please help us. Thank you so much.
I will do. Thank you.
Thank
And
you,
good night,
sir.
everyone.
Yes, sir.
Good night.
Thank
Good
you so much.
night.
Good night.
Good
Good night,
night.
everyone.
Sweet
Family
dreams.
for my mama, strong woman. Well done, man. Good night, man.
Good night, baby.
Good night.
Phone. I love phone. I'm using it.